Perfect. Great. Well, welcome to everyone. It's so nice to see so many people joining us again for our Wednesdays at noon, and it is being recorded. So that's always exciting that we can watch it afterwards. So we have two presenters today, Sydney Breneol and Salma Almukhaini. I'm hoping I pronounce both of your names okay. And we're going to start with you, Sydney. So if you'd like to, do you have something to share on screen?
Yeah, I do. Let's see if I
can. Great. Yeah, we'll let you share and then you can get started. And you're going to be talking about exploring the healthcare utilization. Oh, here we go.
Nice. Okay, does that look right?
Yeah.
Fantastic. Okay. Great. So I'll turn it over to you and you'll have 30 minutes. So however much time you want to present, and then we can include the audience to ask questions or make comments.
Okay, perfect.
Okay.
So thank you all today for coming to this presentation. Like Megan mentioned, my name is Sydney Breneol and I'm a registered nurse and a PhD candidate in the School of Nursing under the supervision of Dr. Janet Curtin. And today I'm going to be presenting on the project exploring the healthcare utilization of children in youth in care of the Child Welfare Authority, a retrospective matched cohort study. And before I go on, I also want to acknowledge the co-PIs on this project and the research team. So Dr. Heather Rose and Dr. Marianne Brown were co-PIs, and our other lovely members of the research team, Dr. Bentelis and Drew, Dr. Andrew Bishop, and Caroline Mitchell, who's an NP also in the School of Nursing. So a brief outline for today is that we're going to talk a little bit about the background, the research questions, the methods that we use to answer such questions, a little bit about the results, but really focusing more on the discussion and the implications of this research. So a quick background is that there are approximately 60,000 children and youth in the care of child welfare. The studies actually indicating that this is an increasing amount. Now, being in the care of the Child Welfare Authority in Canada means that the guardianship is delegated to the provincial territorial government representative, either on a temporary or permanent basis. Now, for brevity and ease of reasoning, we use the acronym, and you'll notice the acronym comes up here and there in the presentation of CYICW to denote children and youth in the legal guardianship of the Child Welfare Authority. However, in practice, we really resist the use of an acronym that can depersonalize and depoliticize the lived experiences of these individuals. And so really just for brevity in the presentation and for the publication reasons, but as I speak, we don't like the use of an acronym. And we know this because children and youth whose lives intersect with child welfare systems are amongst the most vulnerable pediatric populations. Now, the number of children and youth in care with physical, behavioral, developmental, and mental health concerns is significant, with approximately a cited range of 30 to 90% of children entering child welfare care with a predisposing health problem, and 30% had at least 3 or more comorbid conditions, 25% had post-traumatic stress disorder, and 50% had a chronic medical condition. Now, despite increased rates of health conditions, children and youth in care often experience unmet care needs. For example, children and youth in care have been shown to experience several barriers to accessing dental and oral health care as a result of limited resources and coverage. And further, one Scottish study actually revealed that while children and youth in care had higher rates of mental health concerns in comparison to the general pediatric population, they're actually no more likely to access mental health services. Also here in Canada, it's been shown that they also have lower immunization coverage. And this is often or may result from inadequate or fragmented treatment prior to placement that often and may persist upon the entry into the child welfare system. Further, with a lack of consistent access to primary health care and preventative care, children and youth in care often turn to emergency care settings to address their healthcare needs. Now, when we look at the Canadian Pediatric Society, they actually really advocate and they endorse the American Academy of Pediatrics, so the AAP, their guidelines in the care of children and youth in care. And they really advocate for care continuity and the provision of a comprehensive medical, psychological, and dental assessment within 30 days of placement and subsequent routine health screenings. So what was our aim? So as a team of professionals advocating for the redesign of services for children and youth in care, the purpose of the study was to examine the patterns of healthcare utilization from birth to age 18 for children and youth in care in comparison to children and youth who are not in the care of the child welfare system. So how did we achieve this? Well, we employed a retrospective matched cohort study by linking multiple data sets. So we used IWK registration data, the CHI-DAD, which stands for the Canadian Institutes of Health Information Discharge Abstract Data, and MED, which is the physician billing data. And at the time of the study, we did know that there were approximately 900 children and youth who were under the mandate of Child Protective Services. So to identify children and youth in care, and to identify our case group is that all children and youth aged 0 to 18 who visited the Provincial Pediatric Tertiary Care Facility from April 1st, 2016 to March 31st, 2017, and had social worker documented as their guardian on their registration were included in the case cohort. So this documentation of social worker was only documented in this facility at a time when a child and youth was in permanent care of custody of the Child Welfare Authority. So what this also means that children and youth that were in kinship care or temporary care are unfortunately we were unable to identify them based on current data collection structures. So children who did have a valid provincial healthcare number that was encrypted and sent to our provincial data repository system and could safeguard our data, and they did the linking with CHI-DAD, so in physician billings data. And that was really to explore their healthcare organization. And we also used a 1-to-1 sampling ratio. And using that, a control cohort was identified using the hospital registrations data as well, and it was matched based on age and sex. Healthcare utilization was examined from birth onwards up until the end of our follow-up period, which was January 1st, 2018. As this study really was a first step in understanding of how children in the care of child welfare here in Nova Scotia utilize the healthcare system, and also recognizing that there really is a lack of research in this area, both in Canada and internationally, there was a range of outcomes of interest that we decided to look at. So we looked at primary care visits. We also looked at continuity of care. So coming back to what CPS is really advocating for. So is there continuity of care across primary healthcare providers? And this was actually identified using an index called the UPC index, which analyzes, they have to have at least 3 primary care visits, but it analyzes, are they seeing the same primary care provider? And what is the continuity of care? So it's a scale from 1 to 0. 0 to 1, and 1 indicating perfect continuity of care. We also looked at emergency department visits, outpatient office visits, inpatient hospital visits, healthcare provider fee-coded visits for immunizations, physiological development concerns, well baby assessments, mental health visits, and also oral-related health concerns. We used Wilcox rank sum and chi-square non-parametric tests were used, and also to analyze the immunization variables, we actually decided to dichotomize them, so putting into complete or incomplete. So based on the Nova Scotia immunization schedule, immunization status was categorized as children at 6 years of age, having less than 6 unique visits receiving immunizations, or greater than or equal to 6 visits receiving immunizations, and that being a complete. And then we talked about the UPC index, but that was the continuity of care index. And now finally for our results. So sorry, my neighbors are outside talking and getting my dog a little riled up. The final cohort included 200 children and youth in the care of child welfare and also 200 matched controls. So little demographics that we had was that they were 18 infants, there were 61 toddlers, 57 school-aged children, 64 adolescents, and 122 females assigned at birth, so slightly more females assigned at birth in our cohort, and 78 males assigned at birth. And now for the results. So I'm not going to go through each one of these results and repeat them over and over again. However, I do really want to highlight a few of them that we'll be discussing in the discussion and implications as well. So the first one is that we can see here the primary care visits. There was actually no statistical significant difference in the number of primary care visits in and amongst the cases, so children in youth in care versus the controls. However, when we look at lack of physiological development, so these are fee-coded visits from care providers, and also oral health-related visits, so anything, any oral health-related concerns, we actually do see a higher number visits for these instances in comparison to the controls. We don't actually note any difference in continuity of care, which is a good thing. It means that hopefully that they are seeing a consistent primary care provider in both the cases and controls. And also here, emergency department visits. We did actually see a statistically higher rate and number of emergency department visits amongst children within the care of child welfare in comparison to the controls. And a little further on, I do want to direct your attention as well to these mental health visits. And while majority on this side are not statistically significant, we will talk about this, and I'll talk about this a little bit more in the discussion and implications. But we saw no difference except for when we stratified mental health inpatient admissions to a pediatric tertiary care facility. We did actually see a higher number of these inpatient admissions amongst the population of children and youth in the care of child welfare in comparison to the controls. So what does this all mean? So what are the discussions and implications to this research? So we do know that model of service delivery recommendations and policy and research initiatives may vary within and between countries, but one premise really remained consistent when we looked at the literature, is that children and youth are at higher risk for adverse health outcomes and can really benefit from enhanced services to mitigate and attend to their healthcare needs. And so while previous research suggests that children and youth in care often receive sporadic primary healthcare services, our findings did not demonstrate a significant difference in the number of visits to a primary care provider, nor in their continuity of care. That being said, our study does align with previous literature demonstrating that children and youth in care experience higher rates of emergency department visits. Now, this use could be reflective of a number of contextual factors, including convenient access to EDs, the higher incidence of chronic conditions in this population, inadequate or incorrect health information held by foster parents, or an increase in acute healthcare needs in this population. Now, at a health systems level, there has been speculation that improved access to primary care services may reduce ED use. However, while reducing ED use should not be seen as the primary and optimal goal of care for children and youth in care, adopting the AAP recommendations, the American Academy of Pediatric Recommendations, for increased primary healthcare visits for children and youth in care could actually might have a positive impact on both patient and health system levels by improving preventative care strategies. So this is something important to note when we look at our results. Even though we didn't see a statistically significant difference, since CPS does endorse AAP recommendations for the guidelines and management of care of children and youth in the care of child welfare, they are recommending more. So it's just something to note in the context of our results. Now, future research really is needed to explore the impact of the AAP primary care recommendations on the health of children and youth in care, and really help guide policymakers towards evidence-informed recommendations to inform and optimize primary care services for children and youth in care. Now, oral health challenges have been associated with a number of adverse health outcomes, including educational challenges and lower quality of life, with children from marginalized communities often disproportionately affected by poor oral health. Now, our study indicates that children and youth in care do experience significantly higher rates of visits to non-dental physicians for their oral health needs. And here in Canada, our dental coverage varies between provinces and territories, and there's actually only 3 provinces that provide publicly funded dental care for children and youth in care. Now, despite a universal child dental program existing here in Nova Scotia for those up until the age of 10, and the CPS recommending routine dental health screening for children and youth in care, this demonstrates that disparities in oral health may still remain. Our findings really further highlight the critical need for children and youth in care to receive preventative healthcare services to improve their oral health, and really strengthens the call to action from the CPS for more comprehensive dental care. Furthermore, policymakers and clinical care providers really need to be acutely aware of the higher risk of oral and dental disease in this population, and include oral health in their routine assessments, and to really advocate for dental care that is affordable, accessible, and equitable to all. It is widely known that exposure to adverse experiences in childhood places the developing child at risk for poor health outcomes. Now, our study noted a significantly higher median number of visits for physiological development concerns in the population of children and youth in care when compared to their matched cohort. And so our study really does align with existing reports recommended that individuals caring for this population should pay particular attention to assessing developmental progress. And while literature is limited, and especially longitudinal research in this area is limited, international studies have demonstrated that there are increased rates of poor health outcomes that do persist into adulthood. And so primary care providers and all care providers should be acutely aware that proactive, knowledgeable, and enhanced health services could prevent or even mitigate further adverse health outcomes. Now, the AAP, so the American Academy of Pediatrics, has identified mental health care as one of the largest unmet care needs amongst children and youth in care. And so this is where I talked a little bit about the results, but I really want to get more into here, is that even with access to both private and public mental health professionals, many children and youth in care still experience discontinuity in mental health care providers due to the transient living arrangements that are often characteristic of this population. That's also very important to note that in our study, there's only a small portion of our study cohort that had a registered mental health visit, which resulted in our analyses being underpowered to detect potentially significant differences. We're just simply uncertain. However, when we look at these outcomes, many might have had clinical significance. So just briefly going back here, we can see the numbers here. So these are the numbers of visits amongst the cases and controls. There are some differences, and while they might not be statistically significant, they might have some clinical significance, but we do recommend and we do think that more research is needed to really explore this area. It is also really important to note as well, in regards to the limitations and kind of the context of the study, is that there is a significant network of primary mental health care clinicians here in Nova Scotia who are frequently contracted by child welfare delegates and are not captured by data holdings. And so what this kind of means is that at this time, and using only provincial health administrative data, it is not really possible to determine the actual utilization of mental health services amongst children and youth in care at this time. And that future research, doing more complex modeling and a much bigger data set is really needed. However, to accomplish this, researchers, policymakers, and care providers really need to work collaboratively to establish formal partnerships between child welfare and healthcare systems to develop better data collection and sharing methods that can identify and track children and youth in care. And we can learn from other Canadian databases and international databases to achieve these robust data sets. There's actually a great data set in Manitoba called the Population Health Research Data Repository. And this actually this database links family services, education, early development, employment, demographic, and health service databases. And this information is really needed to achieve that more comprehensive understanding of health resource use and the outcomes to better develop evidence-informed policies and patient-oriented policies to attend to the needs of children and youth in the care of child welfare. Now on to our limitations. So again, we talk about all of our results. However, in this research team, we talked a lot about the limitations, but also the limitations being a finding of our research as well. And so the limitations are also the challenges as when I came on as an RA on this project, but also as we moved through and did analysis and all these things kind of came to light. So we want to highlight these limitations as well. Like I mentioned, we are unable to capture utilization in private healthcare. And we are also unable to distinguish between types of primary healthcare visits, such as urgent walk-in settings and primary care offices. We also, and this is very important to note, is that we examined birth onwards who attended a tertiary care facility during one sampled year. And so because of this, and because, like I mentioned, the documented social worker being our proxy to identify children and youth who are in the care of child welfare, that was for permanent care custody. However, we are unable to determine if they had kinship or temporary care, and we are unable to determine, like written here, the time in which someone entered care and what type of care they were receiving. And so this really limited our ability to understand if healthcare utilization changed before or after entering care. And this also might have biased our sample towards the HRM area, so an urban area that's surrounding a pediatric tertiary care facility. And also previously discussed sample sizes restrict our ability to potentially detect any significant difference between cohorts and some of our outcomes of interest. It is also very important to note that race and ethnicity are not included in our current health administrative data sets. and socioeconomic status could not be identified as the postal code that's on record is actually that of the social worker's office. And that the literature is clear that these are critical contingencies in the lives of children and youth in care. And these findings call to action the importance of these data to be available at our provincial, health and administrative databases to explore, understand, and address the intersectionality of these foundational determinants of health on children and youth in care. So in conclusion, this is the first step in understanding the patterns of healthcare utilization amongst children and youth in care here in Nova Scotia, Canada. And our work revealed potential disparities in health service use amongst this vulnerable population in comparison to the counterparts of care. So this includes significant differences in utilization for oral health, physiological development concerns, and emergency care. And I repeat again, at a system and policy level, partnerships between child welfare and health systems are really needed to better develop data collection and sharing methods to identify, track, and optimize the healthcare of this vulnerable population. And much research is still needed and will require cooperation amongst public systems, as well as the political will to support such data sharing and sector collaborations. So I'd like to acknowledge our funding. This was funded by the Development Innovation Grant from Nova Scotia Research Foundation. And I also want to highlight that the data that was used in this report were made available through HGNS at Dalhousie University. Although this research and health service assessment analysis is based on the data obtained from the Nova Scotia Department of Health and Wellness, the observation and opinions expressed of the authors do not represent those of DHW or HGNS. We did recently publish, so if you'd like to see the whole publication, it is in Family Practice that was published last issue. And lastly, I would love to answer any questions if I can. And I also put the emails of both co-PIs, like I mentioned, Dr. Mary Brown and Dr. Heather Rose in this as well.
Great. Thank you so much, Sydney. Very interesting. And congratulations on moving forward and your publication already. That's great. I'm going to open it up to the audience to see if they have any questions or comments first. I know I have a couple of questions, but I'm going to just wait for a moment to see if anyone would like to turn your mics on and ask a question. I guess you can always type something in the chat bar too, but I don't see anything. Oh, yes. Mary Somerville, go ahead.
Hi, Sydney. Great presentation. Nice to see. I know I've seen your printed publication. I didn't get a chance to read it yet, so it was nice to see that today. But I guess I was just interested in your thoughts around virtual care and specifically related to what you're talking about with oral health. Like, I don't know if there's any work at all being done in the space of like dentistry and virtual care. But it just kind of came to mind as you were talking. Is that something that you think there'd be value in looking at?
To be honest, I have no idea. Mostly because, like you said, and like I said, I haven't come across any literature around that when we were working on this work, and so I don't want to say that I'm by any means educated on that topic. I think it's definitely something, especially even in the world that we live in right now with COVID. I think virtual care is becoming more common, and people are looking into it. So it is a potential. But yeah, I would probably defer to clinical experts, but I'm definitely not a clinical expert in dental and oral health. But it would be something interesting to look into for sure.
Thanks.
Hi, Sydney. Great job. Just to kind of butt on that oral health piece, that definitely piqued my interest as well. And as you know, I come from two parents of dentists, so I was like, oh, I'll have to show this to my mom. She'll be very interested. But it is, and I might have missed it. I was kind of preparing lunch at the same time. But did you say that the AAP or NCPS do recommend enhanced visits or more visits in the children and youth in care, that population? And could that be the reason why we see a greater case count, I guess, in terms of oral health visits, or is it kind of more so related to their living situations and perhaps like nutrition. It was all these thoughts of like, oh, what's the factors here that go into it?
Yeah.
And yeah, just love your take. I know we're not dentists, but still.
Yeah.
Yeah.
No, that's a great question though, because honestly, when we noticed that finding, we did talk to a dentist as well to say, what does this mean? And it's important to note that the proxy in which you use the variable itself is it isn't for dentists. It's for it's getting to a point where it's like an oral health concern written by a physician, like going into a clinical office, that it isn't a dentist or a dental like specific office. And so it's a higher rate for oral health related ICD codes. So I'm not sure at kind of a dental level, but it is interesting because it's also kind of brings the importance of understanding exactly what that variable and what that is pointing to, because there are so many different things that are going on, like you said. But yeah, so I think it's more that they're going to physicians, non-dental related physicians more often.
Okay, yeah, that makes sense. And then that would be really interesting then so why is that necessarily?
Exactly.
Yeah, love it. Hopefully someone will pull that thread a little bit further, building off of this study. Yeah, great work. Thank you.
Great. Can you see the chat bar, Sydney? Sarah
Yes.
King had a comment.
Very interesting subject. Do you have a sense of whether the availability of primary care providers in Nova Scotia would have impacted the lack of statistically significant difference between two groups? Even during our study period, we didn't have a robust availability of primary care providers. It's hard to note because there are so many contextual differences, and because we look from birth onwards as well. So this is over a large time period as well, especially for some of the older children that were in our cohort, the adolescents. So I'm not really sure if we can correlate it into the availability of primary care physicians, but that's not to say that that is an area. And what I think is actually, to be honest, most exciting about this work is that it triggers so many thoughts. So we're talking all these, and everyone is asking different questions about different variables, and I think that's what I found most interesting working on this work as well, is that there are so many next steps. So it's looking at, like you mentioned, Sarah, is it the availability of physicians, primary care providers, or can we get to the point and can we really advocate for what CPS and AAP are recommending, is that it's increased primary health care visits. So can we make those services available and ensure that those children are getting the enhanced primary health care visits to potentially identify any or mitigate any adverse health outcomes in the future. So I think any lack of primary care physicians probably would have, my guess, but I'm not sure, would have impacted the case and control cohort similarly. But it's definitely something that's worth exploring in the future.
And there's another comment from Lindsay.
I say, great research. Sorry, this as I had to step away from it. For the identification of individuals within health data, how are they identified? If the health card number is in confidence, that health card number is known by. If health card number, is there confidence that the health card number is known by the system for all children in care? Can you elaborate a little bit more what you mean by known by the system for all children in care? And as you maybe type that, or I'll answer the study and how we identified them. But so collaboration across departments unfortunately wasn't available at the time. However, we had Marion and Heather and the whole research team, this was just before I came onto this project, had to get a little creative on how to identify these children. And so that was kind of step one also of a very interesting finding of how do you identify these children in provincial level health data. And so we actually used IWK registration data, and we just sampled 1 year, and we looked to see who of those have their guardian checked off as social worker. And so in this institution, social worker would be their next of kin and their guardian of note and registration records in the case that they are in permanent care and custody of the Provincial Child Welfare Authority. Now, the difficulty in that is that we are unable to identify those children that were in kinship care or were in temporary care, or when they entered care, or if they left care, and all of these different variables around it with our current data collection structures. we just simply could not find another way. And so that's really why we're really pushing for better data sharing and collection methods, because then we could really gather more robust data sets. And that would be kind of our next step, to be able to identify more of these kids and get a more comprehensive understanding of how they're using the healthcare system. Yeah, so it is, exactly. So it is only based on individuals who actually touched the IWK, who were at a registration, had some sort of visit to the IWK. So yeah, in our case, healthcare number was not easily available for to identify these children in care, and especially when we are trying to find, a big enough sample to say something potentially that has potential statistical significance. So that's oddly why I mentioned again, as our results and our limitations actually really came together, and the challenges of the study came together as kind of one of our biggest findings, that we need better data and that we need them to become more easily available, obviously with all the privacy and confidentiality laws being followed. But is there a way that we can better share our data and better collect our data so that we can develop more health outcomes research and health service research on this population?
Great. Okay, well, thank you so much, Sydney, for your presentation. And thank you to everyone who asked some questions. It is 12:31, so I'm going to turn it over to you, Salma, if you'd like to share your screen. I think you have a PowerPoint.
Yes. Can you see it now?
Yes.
Yes. Just open it here. So hi everyone, thank you very much for coming today. I am Salma Almukhaini. I'm a fourth year PhD candidate at School of Nursing, and Dr. Laurie Weeks, she is here today. Thank you for coming, Dr. Weeks, and Dr. Martin Meissner are my supervisor. Today, I will present part of my PhD research that focuses on role development and utilization of master's-prepared Omani nurses working in a clinical setting at the governmental healthcare system in Oman. I think many of you here are already master's prepared, and you may know that master's prepared nurses have been utilized globally in different roles, including researchers, educators, managers, and most importantly, as advanced practice nurses working as clinical nurse specialist or nurse practitioner. And many positive outcomes have been associated with care provided by master's prepared nurses, including reduction in mortality, morbidity, cost, length of hospital stay, and increase in patient satisfaction. Unfortunately, in Oman, sorry, I forgot to say that I am from Oman, and Oman is a beautiful country in the Middle East. This picture is from Oman. So advanced practice nursing role is not very well established in Oman. In 2016, the first nurse practitioner in pediatric specialty joined the service for the first time, and nurse practitioner role, or Oman is still in the process of regulating the nurse practitioner role, while clinical nurse specialist role is not well regulated in Oman and can be practiced by nurses from different educational background. In 2016, and for the first time in Oman, Sultan Qaboos University College of Nursing started the first Masters of Nursing program in adult acute care. So the majority of master's prepared nurses in Oman actually completed their master's training overseas. Little or nothing is known regarding the role and utilization of master's prepared Omani nurses, and this is all what my PhD research is about. A little background info: healthcare information in Oman is provided mainly by the government, and the Ministry of Health is the primary healthcare institute in which 50 hospitals and 112 primary health centers operate under the Ministry of Health. And Sultan Qaboos University Hospital is the second largest governmental healthcare institute after the Ministry of Health. In addition to Sultan Qaboos University Hospital, we have other governmental health institutes that operate under the military services. So my PhD research aims to answer the following research questions. What are the characteristics of master's prepared Omani nurses working in a clinical setting at the governmental healthcare system in Oman? How the role of master's prepared Omani nurses have been developed, and how are these nurses being utilized? What are the factors that have impacted the utilization of master's prepared Omani nurses? I used multiple case studies. So my cases were Ministry of Health and Sultan Qaboos University Hospital, and I utilized different data sources, including online survey targeting master's prepared nurses, qualitative semi-structured individual interviews with master's prepared nurses, their co-workers, their nurse managers, and the comment review. But in my presentation today, I will just to present the findings of the online survey because I am still in the process of analyzing the qualitative data. So the sample or the population I included all master's prepared Omani nurses working in clinical settings under the Ministry of Health hospitals and Sultan Qaboos University hospitals, and clinical settings included hospital, clinic, health centers, or the nursing directorate offices. I excluded none Omani master's prepared nurses. Master's prepared Omani nurses, those only working in academia and clinical and educational institute or in a private institute, because their path is different. So the online survey that I used consisted of 4 sections with 20 questions, and I think it took around 15 minutes to complete it. The first section aimed to identify the characteristic of master's prepared nurses and mainly ask about the age, gender, when and where they completed their master's education, in what specialty, their current working specialty, and their current working healthcare setting. The second, and I think this is the largest part of the survey, aimed to identify the utilization of master's prepared nurses. So I have question asking them to identify the focus of their current role, and second question to identify the actual and the ideal percentage of time they spend in different role domain, including clinical, education, organizational leadership, consultation, and research. And also I have a question about practice pattern. That meaning they have like different type of activities under education or under clinical direct patient care, under organization and under research, and they have to identify how frequent they are engaging this type of activities. And this part of survey actually was adopted from Canadian master's prepared clinical nurse specialist, a practice pattern survey. The permission was taken from the author, and the practice pattern survey has a high reliability with Cromba alpha ranging from 0.79 to 0.96. However, I piloted the survey to check the phase and content validity, and there were only minor changes. The third section of the survey aimed to identify facilitator and barriers. So there was like a list of facilitator and a list of barriers, and they have to identify the top 3. The last section aimed to identify kind of job satisfaction and ask the participant whether they believe they were currently utilized to the maximum of their educational preparation. I used different recruitment technique because there was no we don't know the number of master's prepared nurses. I asked the help of nursing directors at each hospital to help me, to give me the number of master's prepared nurses and to access them and to send the link of the online survey through their working email. I also utilize WhatsApp Messenger because it's very common in Oman, and I think this is the most effective way and recruited nurses. And also I use snowball technique, in which master's prepared nurses and nurse managers that I know, I ask them to distribute the survey to their network. For data analysis, I use SPSS version 26, and I use mainly descriptive statistics, including means and standard deviation and frequency to answer, I think, the majority of the survey questions, and to answer the question that whether there are any significant difference between the actual and the ideal percentage of time spent in different role domain. I use non-parametric test, namely Wilson, signed rank, because the data were not normally distributed. So the result, according to nurse directors, there were 111 master's prepared nurses, in which 61 responded to the survey with a response rate of 45%. Characteristic of masters prepared nurses, 65% were female and the age range between 32 to 50 years. 67% of the respondents completed their master's education in the last 5 years. Only 8.2% completed their master's education in Oman. The majority, around 70.5%, completed their master's education in the United Kingdom. 19.7% were working at Sultan Qaboos University Hospital, and the rest were working under the Ministry of Health. Those who were working under the Ministry of Health, 42.8% working in tertiary care hospitals, and 32.6% worked in regional general nursing directorate offices. That means they are just doing mainly administrative role. 18.3% working at secondary care hospital, and 4% were working at polyclinic and health center. Around 2/3 of the respondents were working in Muscat. Muscat is the capital city of Oman, and I think because all of the tertiary hospitals are located in Muscat. This table compare between the specialty during the master's education and the current working specialty. So as you can see, 34.4% of respondents specialized in administration during their master's, compared to 47.5% are currently working in administration. And statistically significant difference were noted between those who are currently working in administration and those who specialize in administration during their master's education. The other common specialty included critical care. 11.4% specialize in critical care, and currently only 6.6% are working in critical care. Education, 9.8% specialize in education, and 11.5% are currently working under education. I think the interesting findings here is that 11.2% specialize in advanced practice nursing. And also, as you can see, master's prepared nurses specialize in non-nursing specialty like medical education, pain management, and quality improvement. Here's the interesting part about the utilization of master's prepared Omani nurses. 55% of respondents had administrative-related job title, like head nurse, head of section. 11.6% had education-related job titles like nurse educator, nurse instructor, and 8.3% had a clinical nurse specialist title. And none of the respondents had the title of nurse practitioner. 24% wrote their title as a staff nurse. 58% indicated that their role changed after their master's education. 34.5% described that the current focus of their role is a combination of clinical and leadership, while 32% indicated that they are predominantly involved in leadership and management. 24% only working in education, and interestingly, only 10% involved in direct patient care. And none of the respondents are working with taking care of complex or critically ill patient or patient with chronic diseases. Actual versus ideal time spent in different role domains. So as you can see, statistically significant difference were noted between the ideal and the actual percentage of time spent in research and in leadership. So the respondent believe that they spend less than ideal time in research, so they want to spend more time in research, and also they believe that they spend more than ideal in leadership. And here also, this is from the practice pattern survey, so the second section, activities in different role domains. So generally speaking, the most frequent activities were related to leadership and consultation, and less frequent were related to research and direct patient care. Here in this table, you have some example of the most frequent direct clinical care role activities, such as using critical thinking and synthesis skills, draw on different sources of knowledge, mobilize resources to provide comprehensive care, assess learning needs of the patient, and direct critical role activities like assessment, ordering lab tests, diagnosis, where they are seldomly doing these type of direct clinical care activities. Here also we have examples of educational role activities and organizational leadership. So in educational role activities, they are doing activities like coaching or mentoring member of healthcare team, plan and deliver formal educational event, assess professional development and learning needs. And as you can see, the mean of organizational leadership role activities really high, indicating that they are frequently doing these type of activities like monitoring and evaluating care practice, advocating for organizational culture that support professional growth, identifying and prioritizing issues to improve quality of patient care, facilitate the best use of nursing resources in care delivery. Here also some examples of consultation related activities. Also the mean is considered high, indicating frequent, doing this activity frequently, like providing consultation to healthcare providers to improve the quality of nursing care, or provide consultation to improve the delivery of healthcare services, and provide consultation to improve nursing education program. Research, I think this is also the interesting part. The mean is really low, indicating that occasionally engaged in research-related activities. And even if you can see, most of the research-related activities include utilization of research. They are not actively conducting research. Regarding the facilitators and barriers, manager administrator support were the most selected facilitator, followed by being internationally trained and availability of continuous education. The most cited or the most selected barriers were lack of clear job description, lack of administrator and manager support, and lack of role clarity. This is also interesting findings here. 58.8% of these nurses believe that they are not fully utilized to the maximum of their educational preparation. 26.6% were neutral, and 22.9% believe that they are fully utilized. So from the findings from the surveys indicated that master's prepared nurses working in a clinical setting were mainly utilized in non-direct clinical care roles like administration and education. And there might be some justification for that. One of them is that nursing profession in Oman is considered relatively new, and only 65% of registered nurses are Omani. So we have a lot of expectorate, and it's expected that to first utilize high qualified Omani nurses as a leader and as educator to support the system. Another thing might be related to the personal interest of these nurses and also the status of nursing as a profession. Some nurses found that being in administrative role or education-related role more prestigious than working in a clinical role, especially that clinical role sometimes involve working shifts. So some of these nurses, they just want to have morning shift. The other reason might be that advanced practice nursing role is not well developed in Oman, as we saw, as I already said in the beginning. And then compared to other clinical roles, nursing administrative roles are very well established in Oman. They have clear scope of practice, they have clear job description, and also clear career ladder. While advanced practice nurses and other clinical role, they are not very clear. They don't have like clear job description. They don't have also clear career ladder. Like if you are a clinical nurse specialist today, you will be clinical nurse specialist after 10 years. So there's no progress in their career. Implications for practice, and I think these implications would be also relevant to other country, like other Arab country or other country where advanced practice nursing role is not well established. So to meet the national strategic plan of maximizing the utilization of nursing workforce, patient organization and healthcare system needs that can be met by master's prepared nurses, engineers should be identified, and then national strategies should be in place to assess how current and future utilization of master's prepared nurses could be done to meet those needs. And strategies also should focus on promoting the clinical roles of master's prepared nurses, by increasing their role clarity, establishing well-defined job description, career ladder, and also by increasing support from administrators and policymakers. And most importantly, administrators, policymakers, physicians, nurses, other stakeholders should be actively involved in establishing and implementing these strategies. Limitations: because of low response rate from the university hospital, only 9 completed the whole survey. I wasn't able to analyze the data separately from SQU and from the Ministry of Health. I just analyze, as you see, I analyze the data as one data set. In conclusion, master's prepared nurses are valuable human resources in Oman, and their utilization can be further optimized to support healthcare system in Oman. So thank you very much for listening, and please let me know if you have any question.
Great. Thank you so much, Salma. I'll open it up to the audience, see what questions and comments you have. Just looking in the order, Deanne, I see your hands up first.
I'll remember to take it down. Yes. That was really wonderful, Salma. As one of the nurse practitioners who pioneered the role here in Canada in 1998, when the legislation first came out in Ontario, and while they weren't the first nurse practitioners, they were the first legislative nurse practitioners. I'm really curious because you sort of let us know where most folks got their education. So some was in the UK, some was in the US. And I'm just wondering, because when I think about a new role and I see the limitation of not working to full scope, I'm thinking, well, compared to what? And I think the limitation of not having a clear job description is actually a plus, because the quicker you take control of that, the quicker someone else is going to tell you what you're doing. So I've seen that happen. But my question is, I'm lumbering to a point, did you sort of look at that? What were the influences, where they were educated, and what are the cultural differences that we may not appreciate sitting here in Nova Scotia that would have impacted your data?
Sorry, can you repeat that again?
Oh, just a lot. I was wondering, you mentioned where the nurse practitioners were educated, and most were educated outside of the country. And I also recognize that healthcare is organized differently, and that there are a lot of cultural differences in the way that healthcare is approached. And I wondered if you were able to sort of see that in any of your data.
Yeah, I think, yeah, because actually these nurses, because they are like prepared in different countries, not all of them actually are prepared as masters prepared as advanced practice nurses. So some of them, like, they are prepared as a researcher or in like health policy or in a different specialty. So there's no unity. Even I cannot compare between these nurses because the education is different. So it was really difficult to compare between how the background of these nurses impacted their role, because, like, as I said, the education is different. So I wasn't able to assess how the education impacted their role.
Thank you.
Yeah.
Does anyone else have a comment, question? I don't see any hands up. How did you find data collection, Salma? And where were you when you collected the data?
Yeah, so for data collection, I went back to Oman. It was during COVID last year, started in October. And I think the survey was really challenged, especially that we don't have like a database where we can allocate all masters prepared nurses. And unfortunately, I didn't get a lot of support from Ministry of Health, because when I went to the director of the Ministry of Health, And I was asking him to distribute the survey to all masters prepared nurses. He told me, we don't have a registry for masters prepared nurses. So then you have to go to each hospital in Oman, approach the nursing directors there and ask them to give you the number of masters prepared nurses and to contact them. This is why I think the number of masters prepared nurses wasn't accurate, because it's depend on the report of these nurse managers. And I also find difficulty contacting them through emails because nurses are not checking their emails, unfortunately. So in the beginning, I really have low response rate, but then this is why I start to use the WhatsApp application. I think it was very effective in reaching these nurses. Yeah. But for the qualitative interviews, it was really well. I really have a high response rate from the nurses. They're really excited to participate in the study, and they tell me a lot of information. They were open to discuss the challenges they have. So it was really interesting. And still, I'm glad that I have like 50% response rate.
Wow, 50%. That's excellent.
But unfortunately, I was surprised to get low response rate from the university hospital. Only 12 nurses respond to the survey. And I think maybe because they were really busy with COVID, so they don't have the time to really fill the survey.
Right. Yeah, so many factors. I always find it really interesting to see how data collection goes and who participates.
Yeah.
Great. Okay, a couple more minutes if anyone else had a comment or question. A couple of notes in the chat bar, Salma, if you can see those.
Yeah, thank you very much, Lindsay and Sydney, and Brianna, thank you. And Deanne, yeah, I totally agree with you. I was afraid in the beginning that they will not open up and they will not share their stories with me, but no, I really surprised to see how come they are really willing to tell me their story and the challenges they have, and they even helped me to recruit other nurses, which was great.
Yeah, really comprehensive study that you're doing. So I want to say thank you so much to you, Salma, and thank you to Sydney for your presentations today. And we know where to reach you, I guess, if anybody has any further questions or comments.
Right.